Hello everyone. Today we shall look at the pox viruses, Gianotti-Crosti syndrome, and then infections with hepatitis B and hepatitis B as they affect the skin. I'm Dr. Abraham from A&E Dermatology Specialists. So in today's outline, we have hepatitis B, C, and then the skin manifestations. We have Gianotti-Crosti syndrome and pox viruses and their manifestations when it comes to skin. So to start with, we have this picture that highlights a few of the conditions that have been associated with hepatitis B and C. In the first picture here, where you see my cursor, we see rashes on the dorsal aspect of the hand with erosions, ulcer, dyspigmentation, and also bristling. And this is porphyria cutaneata, which is associated with viral hepatitis C infections as well as hepatitis B. In this second picture here, we see a little bit of erythematous plaques with scales. And in this case, this patient had what we call polyarteritis nodosa. And at the end of it all, they develop these erosions. And that is also associated with infections of hepatitis B and C. Then in the middle picture here, we see a reticulate erythema on the skin of this gentleman. And this is what we usually see, or the diagnosis we call livido reticularis, and it has also been associated with infections of hepatitis C. So when you look at these two viruses and their skin manifestations, we know that hepatitis B and C, they come from different families. Hepatitis B is in the family Hepatidina-viridae, which consists of double-stranded DNA viruses. And hepatitis B is usually transmitted via blood or any bodily fluids, including sexual contact, sharing needles, and it can also be transmitted from mother to child. We see it in part of the torches that we shall cover later on, that it can also be transmitted from mother to child. Symptoms usually include a fever, fatigue, yellowing of mucous membranes, dark urine, and it can complicate into chronic liver disease, liver cirrhosis, cancer, and then luckily enough, this can be vaccinated. And in Uganda, the current vaccination trend, you're supposed to receive about 3 doses. The first dose at day 0, then the second dose after 30 days, then the last dose is usually given after 3 months or 100 or 90 days. Those are like 3 months, 90 days. Same, hepatitis C comes from a family, Flaviviridae, and it is a positive sense single-stranded RNA virus. It was also transmitted through blood or sharing needles, can also be sexually transmitted, but this is rarely. But currently the trend is the infection is high amongst those that use IV drug medications, especially IV drug abuse clients who do intraventricular injection of heroin or those methamphetamine or the rest. It can also be given from mother to child via vertical transmission, and still the symptoms are similar. On top of that, you can also have right upper quadrant pain where the liver is located. Still, hepatitis C has been associated with chronic hepatitis, liver cirrhosis, and as well as liver cancer. So luckily enough for hepatitis B, at least it has a cure. Once you have diagnosed a patient, you have a lot of treatment options, though not really available in our setting, but at least if it is possible, we can get ribavirin, we can get interferon alpha, and then these other drugs are not really available. The teraprevil and then Grazoprevil, a combination not yet available, but at least interferon alpha and ribavirin can be maybe accessed. So when you look at the skin manifestations of hepatitis B and C, these ones I usually classify them, and I say they're about 15, and I prefer using this table that you see here. Now that in this table, it will indicate for you the type of virus that is most associated with that particular skin manifestation. The first one is what we call small vessel vasculitis or inflammation of small vessels, and this has been linked to both hepatitis B and hepatitis C. We have also globinemia vasculitis, which is more in hepatitis C compared to hepatitis B. Then at cardiovasculitis for both B and C. Polyangiitis nodosa, we've seen a picture, and this is for hepatitis B. Then we also have levodoticularis, which picture we have seen, and this is usually associated with hepatitis C. Serum sickness-like reaction for both of them. At carrier, for both of them. Gianotti-Crosti, we shall see this shortly, but it's for both of them. And then necrolytic acroerythema, this is really seen in hepatitis C infections. Then porphyria cutanea, it has also been linked to both hepatitis B and C. Then pruritus for both of them. Lichen planus has been linked to hepatitis C. Then sarcoidosis for both of them. Erythema multiforme and erythema nodosum for both of them. So just to remind you in the picture, in this picture, this is sarcoidosis, and those are lichenoid papules. This is levodoticularis, hepatitis C. This is polyangiitis nodosa for both of them. This is porphyria cutanea for hepatitis C. So when you go to necrolytic acroerythema, which is a manifestation of infection with hepatitis C, this is a rare skin condition, usually characterized by scaly red and painful patches, primarily affecting the extremities, but most commonly on the lower extremity. This one we mentioned earlier, it is associated with hepatitis C infection, and it is the lesions are located on the hands, feet, and lower limbs, as well-defined scaly erythematous patches or plaques. So sometimes it can present with a little bit of itching, burning sensation, though some patients report some bit of pain. And in severe cases, it can advance and develop into blisters and erosions. So when you're diagnosing this condition, you'll do serology, you'll do hepatitis C titers or screening tests, antigen body tests, and then in case you've confirmed the treatment, you treat the underlying cause, which is hepatitis C. Then you can also supplement with zinc and other amino acids. And then locally, we can apply topical corticosteroids to try and address the inflammation that comes with this condition. So as you can see in this picture, this is a well-demarcated scaly hyperpigmented plaque that is on the lower ventricle. And this is how necrolytic acroerythema will look like. So you see that, like you should remember, in the word acro means extremities, erythema means redness and more blood pumped to that area. Then necrolytic, that means that there's death of cells. So that's how it will manifest. Then we can go to the second condition of today, Gianotti-Crosti syndrome. In this case, it's also called the papillary acrodermatitis of childhood. And I usually love these namings where the description of the disease is actually in the diagnosis. Papilla, meaning that the child will have papules, as you can see there, erythematous papules. Then acro, meaning that the disease will affect the extremities like the hands and feet. Then dermatitis means inflammation of skin, and of childhood, meaning basically this condition is seen in children. So Gianotti-Crosti syndrome is a viral echinanthem which usually affects children aged between 6 months and 14 years, with 90% of the cases occurring by the age of 4 years, meaning that as above 4 years, little children or few cases will be reported for this condition. So initially, the leading cause was hepatitis B, but because of the vaccination, currently the leading cause is Epstein-Barr virus, and other viruses, bacteria, and vaccinations have also been implicated in this condition. This Gianotti-Crosti syndrome also demonstrates what we call Koebner phenomenon. And in Koebner phenomenon, it means that, for example, if someone has the condition already and then they get an injury, or for example, if you get an injury of this size, then the lesions will appear along the line of injury or the line of scratch, forming a linear pattern or a pattern following how the injury went, how the injury was on the skin. So that's what we call Koebnerization. Luckily enough, Gianotti-Crosti syndrome is self-limited, and even without treatment, it will resolve in a few weeks. So this table tries to categorize and highlight the most common implicated viral infections, bacterial infections, and also the vaccines with the viruses, including hepatitis B, which has been now replaced by Epstein-Barr virus. Other viruses include CMV, Coxsackie, respiratory syncytial virus, adenovirus, parainfluenza, human herpes virus, human herpes simplex virus 1, and even HIV. So other non-viral causes, these are the bacteria that have been implicated, include group A beta hemolytic streptococci, and then Mycoplasma pneumoniae, Botronella hensii, and then also Neisseria meningitidis. So when you are to look at the vaccines that have been implicated include polio, include the DPT, that is diphtheria, pertussis, and tetanus, and also MMR, which is mumps, measles, and rubella vaccine. Also, sometimes hepatitis B vaccination and hepatitis A plus influenza have also been reported in a few isolated cases. Gianotti-Crosti has been given a proposed diagnostic criteria, which has 4 positive signs that usually account for it, and 2 negatives that are usually against it. In the first positive is that the patient will have monomorphous or monomorphic flat papules or papulovesicles to 10 millimeters in diameter, as you can see in this picture, and usually most of them are usually discrete. Then the sites that are involved are usually 3 or 4 of all the following. Someone should have a rash on the face, the buttocks, the forearms, and then the extensor legs. So this is what you're seeing. This is the extensor part of the leg. This side is the extensor, this other side is usually the flexor. So then symmetry, meaning that the rash should be on either sides of the body, left and right, and at least it should have stayed for about 10 days or more. And we say 10 days because we see other viral exanthems that usually be there maybe for a week or maximum 2 weeks, and then they disappear or resolve. But Gianotti-Crosti should make a diagnosis if someone has had the rash for at least 10 days on presentation. Now, the negative clinical features that and against Gianotti-Crosti, in case you have extensive truncal lesions and then also sickly lesions, this one is usually a negative. And luckily enough, it being a viral exanthem, there's no treatment actually that seems to shorten the duration of the disease. So when you see these patients, you manage symptomatically. If there's some mild itch, if there's superimposed bacterial infection, you address those, and the child will be okay in a few weeks. So we go to the next group, the one we call the pox viruses. So this group has been with us for eternity, and luckily enough, it is one of the commonest things that we see, and someone should have an idea of how it looks like. So this pox group, it is one of the viral group that has a very big DNA or even molecular size that even on routine stains, when you take off a biopsy from the skin lesions, you're able to see the virus within the cells. And there are DNA viruses with a very high molecular weight, with a diameter of about 100 to 300 nanometers. And as I've mentioned, it is also seen on routine stains. So in this group of viruses, or in this family, we have 2 viruses, the molluscum contagiosum virus and smallpox, that are only known to be residents or where humans are known to be the hosts and then also reservoir at the same time. The rest of the virus in this group usually affect other animals, and humans end up to be accidental hosts. So these other viruses include the vaccinia, include the monkeypox, the cowpox, buffalo pox, camelpox, and the rest, even hunter pox. So what you have to note and remember is that in all this group, in one or the other, they usually form some imbricated papule or pustules somewhere. So every time you see an imbricated papule, think about a viral infection from the pox family as one of your differentials. So the first one is what we call smallpox. So smallpox is also called variola major. And luckily, you will never see this case unless when it reappears, but it was eradicated in the 1977, but it is still significant dermatologically because it is still considered a possible bioweapon. So, People can be storing this virus somewhere, then they bring it back as a weapon to try and kill other people. So you need to know how it looks like so that you can recognize it. So transmission is usually through the respiratory tract or direct contact with the lesions, and it has an incubation period of about 10 to 12 days. And this is usually preceded or this is followed by a prodrome of fever, which is above 40 degrees Celsius, lasting for about 2 to 3 days, a headache, and then back pain. So after that, the patient will now develop a rash in the mucosa with what we call an anthem, and it will cover the tongue or oropharynx and the mouth as well. 1 day later, the patient will now develop an exanthem, and this is how the progression is. So someone starts with macules in about 1 to 2 days. These macules now turn into papules in about 2 to 3 days. Squeleted will become vesicles in 4 to 7 days. Then later on, they will become infected and then there will be pustules. So after that, then they will crust and then form scars. And the evolution of all this process takes about 2 weeks. The diagnosis can be made using PCR and then direct fluorescent antibody, but drug tests can also be done since these viruses can actually be seen on routine staining. The treatment is usually you have to isolate the patient, and the antiviral that can be given in this case is cidofovir. So as we can see in this picture, so this is what we call an umbilicated papule. If you can see this is a papule, but on top of the papule, there's this punctum, like depression. That is what we call the umbilicated, but we're just looking like like the umbilicus or the navel of every individual. So that's how they will look like. And this is the same picture all over the body. And we've said that even the mucous membranes can be affected. So we go to the second virus that we call vaccinia. So this was made in the lab after modification of another virus in this group, just vaccine against smallpox. So it was first isolated reportedly from horse hooves by Jenner, and it has been used ever since then to try and vaccinate people against smallpox. So this vaccine is given as a live vaccine, and the abnormalities or the abnormal immune response of the host can result into skin manifestation. So, and the skin manifestations that you can get in this case include the following. You can get an auto inoculation, for example. You inject the hand, then the child picks maybe scratches that hand and then touches the face. Then you have spread of vaccinia to the face or even the rest of the body. Then we can have generalized vaccinia, which usually occurs about 6 to 9 days after the child has received the vaccine, and it will present like with fever and lesions, which usually are similar to erythema multiforme, but at the end of it all, they turn out to be umbilicated papules that we've seen earlier. So we also have a phenomenon we call eczema vaccinatum, which usually occurs in patients who are atopic and also others that have disorders of conification, and it is similar to the ones that you've seen before, the eczema hepaticum and then eczema coccicum that we've seen in the other presentations. The other complication that can come with vaccine is progressive vaccinia. We're going to look at a picture, and in this case, where you inject someone with this vaccine, they develop an ulcer that becomes necrotic and progressively eats away tissue, including muscle, fascia, and even it can go as deep as the bone. Then other reactions that can usually get, you can have benign hypersensitivity reaction to the vaccine. This one can present with arterial lesions, erythema-like lesions, morbidiform lesions, and there is just like any hypersensitivity reaction. Then the post-vaccination follicular eruption is also another reported reaction. And in this case, you get follicular eruption or around the hair follicles all over the body. Then we have also noted a few case reports which suggest that at the site where smallpox is vaccinated or the vaccine is given, some patients have later on developed malignancies, including squamous cell carcinoma, basal cell carcinoma, and melanoma. So this is how they disseminated eczema vaccinatum will look like. So in this case, the child is maybe immune compromised or the child is atopic, and then you give the vaccine, then they'll end up with this extensive umbilicated papules that look like smallpox, or that look like all conditions in the pox viruses family. And this is how Vaccinia gangrenosum or this is how Vaccinia gangrenosum will look like. And in some cases can be so severe and it goes up to the level of the bone. And in this case, you have to manage the patients in the due time to prevent complications. So we go to the human monkeypox virus. So as we've said earlier, that the only two of these viruses in this pox family or poxviridae are known to be hosted or by humans. The rest come from animals. So the first one is the human monkeypox virus. This one is sporadic, zoonotic, and common in West Africa, including Democratic Republic of Congo, and because of this, we need to know how this will manifest. Usually, it is thought that the vectors in this case include rodents and monkeys, and humans end up as accidental hosts. So, when you get this infection from the monkeys or the rodents, then you will get skin manifestations. Then the few cases that we reported in the USA, literature shows that they were due to prairie dogs, and these prairie dogs had been or had interacted with the rodents, ending up infected, and then the owners of these dogs ended up acquiring this viral infection. It usually occurs in children below the age of 15 years, and the mortality ranges between 1 to 8%. It has an incubation period of about 10 to 14 days. Then after that, someone will have a fever, sweats, chills, headaches, and in this case, headache is usually 100% of the cases, and then lymphadenopathy in about 90% of the cases, as opposed to the smallpox, which usually there's no lymphadenopathy. In this case, you'll have lymphadenopathy. And then after that, someone will get generalized monomorphic umbilicated papules with involvement of the mucosa. So this is how the lesions will look like, as you can see in this picture, just like all the other pox viruses. So the next are the buffalo pox. This usually affects cows, and buffaloes and humans, as we've said, they just end up as accidental hosts. There was an outbreak in India, but it was controlled. And in this case, lesions are common on hands of the farmers. And this is how they will look like. The same way cowpox will look like, cowpox comes from the udder of the animal by the cowpox virus, and someone will end up with what we call Maker's nodule, which will also look like the same umbilicated erythematous papule or flake. Then we have what we call off or eczema contagiosum, and this one comes from sheep or goats. So people who are goat farmers, sheep farmers, they can get this virus, and they'll end up with the same manifestation as you can see in this picture, this umbilicated papule with an erythematous base. Then the human hunter, the human Turner pox virus, this one's endemic to Equatorial Africa, and from primates, it comes from the chimpanzees, the gorillas, and usually it also has okay lesions, and also these lesions sometimes resemble cysts. So we can continue to the next one that is usually common, unless every practitioner has seen molluscum contagiosum. But now in this video, we shall highlight how do you manage it. So molluscum contagiosum is a group of viruses, number one, there's one up to four. And usually molluscum contagiosum virus number one is common in children and worldwide. And then two is usually common in people living with HIV, contributing to up to 60% of the cases. Then 3 and 4 has been reported in transplant patients. And this virus is spread by skin-to-skin contact or even auto-inoculation when someone has one rash and then they scratch and touch another area. So molluscum contagiosum loves the three categories of people. The first one are the young children, the ones below 4 years. And those ones get the infection from school, overcrowded kindergartens and the rest. Then it can also be sexually transmitted when, and this is the group that is usually affected, the sexually active young adults about 20 to 29 years. And these ones you find lesions in the around the genitalia, around the face as well. And then the last group is the immune suppressed, especially those living with HIV on chronic suppression, chemotherapy. They can also present with molluscum contagiosum. So the lesions in this case will vary in size, small ones, big ones, giant ones, but all of them will be firm, smooth with a like pear papules with a central amplification. So when you see someone with extensive molluscum contagiosum, you need to do they have DOC8 deficiency or do they have any immune suppressive state? So molluscum has been thought to persist on the skin because of what it does to your immune system. And the first mechanism that is postulated is that the virus itself directly inhibits the nuclear factor kappa beta that prevents your immune system to recognize and fight against it, because nuclear receptor kappa beta is very key uh, um, in stimulating the production of pro-inflammatory cytokines that end up activating the immune system. So if you're able to inhibit it, it means that you can evade the immune system. The second mechanism that has been proposed is that molluscum contagiosum virus produces interleukin-8 binding protein that usually blocks the response from T helper 1 cells by reducing the local production of interferon alpha. We all know that in viral infection, the very important immune response is interferon alpha. So if a virus is able to block the production of interferon alpha locally, then it can thrive. That's why you have those molluscum on the skin. So what are the different differentials in this case? So we have to think about other infectious conditions like cryptococcus, histoplasmosis, coccidioidomycosis, Penicillium metheny, then keratoacanthoma. If the rash is on the face in an elderly patient, then desmoplastic tricholemoma. So in the treatment option, the first one that I usually love most and people never agree with me is the benign neglect, because usually after 18 months, the body will be able to fight and exclude the virus completely. But patients will be concerned that maybe the child is how the child looks like and they want you to do something. The other treatment options that are available, we have cementidine, though not well tolerated because of the adverse effects. And these days it's even hard to see on market. Then you can do nicking, where you get maybe a surgical blade or a needle, and then you irritate the top of each lesion. Then that triggers an immune response that clears them off. You can do light cryotherapy. In this case, you get your liquid nitrogen, and then with a gauge you direct it towards each lesion. Then you can also inject candida antigen in maybe about 3 to 5 rashes, and then the immune response that will be stimulated will end up fighting all the lesions. There's also a possibility of using 1% hydrogen peroxide cream on the lesions. You know, hydrogen peroxide is a little bit aggressive when it comes to skin. It can dissolve proteins and the rest. So when you use it, that's why you're using a 1% cream, and it will also be able to help you. You can also do pulse dilator. So this is not really available in our setting, but if it's available where you're working, you can also use this as an option. Then we can do topical tretinoin, cidofovir, and 5-fluorouracil. However, the effectiveness of this is not a lot. The intention is just to irritate the skin, the immune system wakes up and then fights the viral infection. You can also use the 30 to 100% tricloracetic acid. So that's how the lesion look like for molluscum. I think you've seen this. This is now familiar, umbilicated papules. And that marks the end of our session today. Remember to like, comment, share, and subscribe. Thank you for watching. I'm Dr. Abraham. God bless you.